Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome back to the Health Upgrade Podcast. This is Dr. Habib. I'm here with JP, my co-host. How are you, sir?
I'm doing really well, and I'm looking forward to saying "Go Bears."
Yes, and go Cubs.
Go Cubs, yes.
So rarely do you get a chance to actually say that, and it means something, right?
Exactly.
It's been about 1918 was the last time you could say "Go Cubs," right? I'm just making a joke here. No, they won. I know.
Yeah,
I'm just making a joke.
Let's all just take a step back.
And our wonderful friend and guest today, Dr. Sanjay Bhojraj. This episode of the Health Upgrade Podcast is brought to you by Truvaga. Have you been looking for a simple way to feel calmer, think clearer, and sleep better? Imagine achieving this with just 2 minutes a day. I'm excited to introduce you to Truvaga, a handheld device that supports your nervous system through gentle vagus nerve stimulation. As a doctor specializing in functional health and wellness, I've seen firsthand how Truvaga has accelerated healing in my clients. I've used this device to help people with a range of issues, from sleep disturbances and heart palpitations to digestive dysfunction, nervous system imbalances, and mental wellness concerns. The results have honestly been remarkable. Truvaga is designed to catalyze and accelerate the shift in your body from fight or flight to rest, digest, and recover mode, helping you manage stress, maintain mental clarity, and unwind more easily. It's not just theory. I've witnessed its positive impact on real people facing real health challenges. The best part? Truvaga fits seamlessly into your routine. No need to carve out hours for wellness. Just 2 minutes a day can make a difference. It's a small investment of time for potentially significant benefits in how you feel and function each day. If you're curious to experience Truvaga for yourself, visit truvaga.com/upgrade. You can save $30 on your device by using the code UPGRADE30 at checkout. Remember, that's truvaga.com, truvaga.com/upgrade. It might just be the first step towards a calmer, clearer you, just as it has been for many of my clients. It's great to see you, brother.
Hey, so good to see you, JP. Great to meet you. So happy to be on the podcast. Thanks for having me.
We're excited to dig into a few topics, things that you are a specialist in and one of the world's best in. And we're really excited to kind of learn from you and have a wonderful discussion regarding cardiology, Clotho, a few different kind of topics. What brought you into the functional world as well? Yeah. And we'll get into that. And let's start off with that story. Let's start off understanding your journey into the functional medical world, functional medicine. What brought you in and as a cardiologist?
It's definitely a less than normal career path for an interventional cardiologist like me to get into functional medicine. But I think for me, it's the most obvious thing, right? So for those of you who don't know, an interventional cardiologist, I was the heart attack doctor, right? So I did 3 years of internal medicine, 4 years of med school, 3 years of internal medicine, 3 years of general cardiology, and then did an extra year on top of that to specialize in cardiac procedures. So I was the doctor that would put in cardiac stents, which are these little spring coil things that you can put in the arteries to open up blockages. So most of us are probably familiar with that in the setting of heart attack. And then I also trained in structural heart disease, which is kind of a new area in the field of cardiology. So I was doing heart valve replacements through the arteries in the legs and putting in plugs so that the blood vessels or blood clots wouldn't leave the heart, and little clips on the heart valves to get them functioning correctly. So a really technical, subspecialty within cardiology. And I remember like the weekend when the bell cracked for me was probably about 4 or 5 years ago when I was on call over the weekend. And when you're in, at least in the practice that I was in, when you're on call for the weekend, call starts at 8 a.m. on Friday and ends at 7:59 a.m. Monday morning. So you're on for 72 hours for all heart attacks that come in, right? And there was a Saturday on call where I had 8 back-to-back heart attacks. Right. And it's just physically demanding. I mean, everything is life or death. You're just in the moment. I mean, I used to think of being in the cardiac cath lab as my version of meditation because nothing else in the world mattered, right? I was focused on the task at hand, did it, and then I would just kind of fall apart afterwards. And probably by heart attack 6 or 7, I kind of had my WTF moment in the sense of, number one, what is this doing to my health, right, as an individual? Because at that time I was in my probably early to mid 40s. And I'm like, boy, I'm not going to last to my early to mid 50s if this continues, right? But then I kind of realized for the most part, cardiovascular diseases are avoidable, right? Or at least manageable through diet and lifestyle. And I looked back and realized I have no background in this whatsoever. In medical school, for the healthcare practitioners out there, we don't get nutrition training really outside of biochemistry. I can tell you what alanine and leucine and isoleucine and all the amino acids are, but in terms of proteins and carbs and fats, outside of knowing how many kilocalories per gram they have, we don't get really a lot of background in this. And in fact, it's almost like a meme, right? Like my father-in-law just went to his doctor, his primary care doctor. My father-in-law, love him in pieces, he's slowly with age getting diabetic. And the great advice that his primary care doctor had was eat less and exercise more. Like it's just the perfect example of, checking the box, diet and lifestyle checked. I can probably upcode for that. We talked about diet and lifestyle, but it's just not something kind of workable. So through a series of odd kind of circumstances in life, I tell you, it's like you just kind of got to go where the flow takes you, right? So through a series of weird kind of circumstances, I got an email from some supplement company about functional medicine approach to hypertension. And at this point, I'd been a cardiologist for about 15 years. And it was kind of like teach me something new, right? Yeah, go ahead, try, right? Kind of moment. I was really kind of skeptical getting in. And when I heard the lecture, and they, of course, did not focus on ACE inhibitors and ARBs and beta blockers and calcium blockers, but rather hypertension is an inflammatory condition. And that's something that I had never heard of. But the science is there, right? The basic science is there. There's this science translation gap between the bench and the bedside that exists because, as a practitioner, you're so busy trying to keep people alive that you're not reading every paper that comes out and you're not, kind of learning about all these things. And certainly I think there is a reluctance in the conventional medicine world to believe that diet and lifestyle can absolutely make a difference. Even though every guideline we have in cardiology, hypertension, arrhythmia, heart failure, insulin resistance, hyperlipidemia, every single guideline says the first, like class 1A level of evidence, the first thing that you need to do, 3 to 6 months of diet and lifestyle interventions, right? But I can count on probably this many fingers. How many, for those of you who are listening audio, that was 0 fingers I was holding up. How many times we were taught that in training. And, probably I trained at a stodgy, I love my training program, but, if I had said, hey, let's try some broccoli for this patient's hypertension, I probably would have had like an instrument thrown at me or something, like a scalpel chucked in my way or something. So through this, one lecture on the inflammation and hypertension connection, that kind of cracked my brain open to say, hey, you know what? I think I need to think of this a little bit differently. And as an interventional cardiologist, we are trained by our very nature and probably a degree of personality that we're like the problem solvers, right? It made a hard time for my first year of marriage for any of you who's married out there, because sometimes you want to, your spouse, your partner wants you to just listen to the problem versus fix the problem. And I'm a fixer by nature, right? So, it led to a lot of interesting conversations, let's just say.
I think every father and every dad and every husband out there with you right now, I feel you, sir.
Join the club, right? And so kind of what I realized is, as an interventionalist, kind of that mindset to fix, I need to have every available tool. And I think that for me, a huge tool, and now I've kind of shifted my career to this aspect of diet and lifestyle, where there's actually evidence, and the evidence is so good that if this was a pill that you could take, it would be a multi-billion-dollar pharmaceutical, right? But instead, there's no money in broccoli and kale and deep breathing and vagus nerve activations and things like that, right? So from an insurance standpoint, right? So as a result, the conventional universe doesn't really teach that to the trainees. And so as a result, it never becomes part of the toolbox that you've got. But now I can tell you, being a functional integrative cardiologist, the consumer demand, like patients, this is what they want. And it's amazing to see the transformations that people can have with these diet and lifestyle interventions, getting people off of medications, right? I kind of joke, the first 15 years of my career were spent adding to people's medications list, and the last half of my career is going to be taking people off meds. And it's amazing, how many non-pharmacologic or non-surgical interventions there are out there that are so effective. And that's what I just absolutely love about this functional medicine universe and this mindset, is that there's so many things that we can do that are so effective let's engage those, right? I'm not saying you never need medicines, right? But you don't need all the medicines, right? Maybe you can get away with half of a dose or a tenth of a dose, if you can manage the diet and lifestyle. So it's an interesting journey, and I am so glad I'm on it. It's just really kind of changed my existence, but it makes me feel like I'm actually doing what I'm supposed to do.
Yeah, my perspective on this is that human beings evolved over, hundreds of thousands of years. And frankly, going back, since our ancestors before that go back, a billion years, there's just no way that people can tell me that somehow human beings are naturally predisposed to being ill, and that we're not, in chronic illnesses can't be managed by changing lifestyle, diet, sleep, stress levels, et cetera, because we had to up until the advent of modern medicines, which is just about 120 years old.
Yeah. I mean, that's exactly what I was going to say is you look at these ancient healing arts like Ayurveda in India and traditional Chinese medicine and all of these things. I mean, they work. I mean, probably a lot of people died using the wrong plant and they realized, oh, let's not use that plant. Let's use the other one, right? But, there was, we may not have had randomized controlled trials of, this herb versus that herb for this condition versus that condition, but you definitely had empirical evidence, right?
But, those randomized trials also, what we've got now are medicines that work on the average.
Mm-hmm.
They don't work for you.
Yeah.
They work better than placebo in 1,000 people. Now, that could mean that there's 200 people that get worse on that medication.
I mean, that's a great point. And that was part of the entry into the functional medicine world. So there's a medication called clopidogrel, right? Which is a anticoagulant, a blood thinner, antiplatelet medication. We use it like water in cardiology for like almost every condition. And when you look at that clinical trial, and I may get the numbers wrong, but the clinical trial outcomes showed an 11.3% event rate in the placebo group and a 9.3% event rate in the treatment group. And so this became a blockbuster medicine based on this 4%, relative risk or absolute risk reduction, blah, blah, blah. But you still had 9% of people having an event on the medication, right? It wasn't zero. And to your point, JP, I always say population-based statistics do not apply to an individual, right? So
and how do you know that it was really only the difference between, I think you said 11.3?
9.7 and 11.3 here. I can kind of pull it up.
Like less than 2%. But was it the same people? Are you saying to those 9.7%, you would have had the event anyway?
Right.
So, or are we saying, no, the medication actually fixed all 11.3, but it caused for 9.7% who wouldn't have had an event? Now you had one.
Right. So we don't know, right? And I think that, you mentioned, the medical sciences, if you think about it, it's like the youngest of the sciences. Maybe rocket, science, maybe, but you think about physics has been around for forever. Chemistry existed since alchemy, right? Like 100 million years ago, all that stuff. But medical science really didn't have science behind it, really, I think, until the advent of penicillin, right? And that was even a mistake. Dude forgot to wash his dishes, and then all of a sudden there's a mold that's growing, right? I mean, you want to talk about things that husbands can relate to, right? That's why I never do the dishes, because I'm like, babe, it's a science experiment. But, we think as, scientist humans that we have all the answers. And I think the body just, humbles us on a daily basis, right? And as we talk about, this is where I get a little bit metaphysical, but there were, patients that, were so like they had major heart attacks and all these things. And literally I felt like the only thing I could do was pray for them, right? I did whatever medical science allowed me to do. And then I was just like, dude, God, do me a solid, get this guy through or get this woman through. And then, the energies that we put out and the healing, the healing fields and all that stuff. And patients, lo and behold, got better inexplicably, right? And so, I think that there's so much more to healing than medicine. And, and getting back to the healing arts and Ayurveda and stuff, the remarkable thing is now we're kind of filling in those blanks of the science behind these traditional therapies. I think of that Big Fat Greek Wedding movie and Windex, right? I mean, that's turmeric, in the Indian culture. Like there is nothing turmeric can fix. You could have break a bone and my grandma was making a paste out of turmeric and whatever. And now we've learned that that's curcuminoids, right? And there is actual science behind it. You look at, it's just culture, kind of what I've got, but like Indian spices, like all of these things have healing properties as well. So there's wisdom, we just have to uncover it. But, the nature is the smartest thing to have ever existed, right?
We get all the medicines from to begin with. We get it. We get all of it. original compounds from plants and animals, throughout the world.
Yeah. And people don't realize that, right? I mean, do you remember this old movie with Sean Connery, Medicine Man? Like he goes in the rainforest and like that was the first time I realized, I mean, that movie must have come out, maybe I was in high school or younger, I don't remember. But I was like, wow, I didn't realize that plants are actually the basis of a lot of these things. And even if you look at like statin drugs, right? Like as a cardiologist, and we can talk about statins and the controversy there, but that was derived from red yeast rice, right? I mean, that's the naturally occurring statin, right? And then, and so, I think we have to honor kind of nature. And, I think rather than vilifying it and saying that doesn't make sense, say, all right, well, how can we make sense? And that's what I love about what I get to do now is really integrating kind of all these different modalities. And look, if you need to be on, you had 3 heart attacks and 5 bypass surgeries and you need to be on meds, there's some times where we can't avoid that situation. As a conventionally trained doctor, I can't in good conscience say, do some, deep breathing, box breathing, and like not saying that it wouldn't have an effect, but we have to kind of balance the science and our experience. And I think balance all modalities of care, right? Because I think ultimately it's not about my ego as a practitioner saying conventional medicine versus integrative functional, but rather what's going on with the patient? How do I make this person feel better? And to your point, JP, that's not a randomized controlled trial, 4,000 patients in this arm, 4,000 in another. It's looking at the person across from you and saying, all right, where can I meet you, right? What are the things that you believe in? Like, would you want to try this? And then creating a plan for that person based on that, right? So anyway, getting back to the story. So 8 heart attacks led me here. Luckily, none of them were mine.
I want to ask though, because you focus a lot on what you could do for your patients, cardiology, interventional work that you were doing, you were focused on them. When you had that first moment where the bell cracked and you started leaning into this idea that inflammation is kind of one of the pathways by which, or the pathway by which hypertension occurs, did you start to implement some of these tools or ideas in your own health, in your own journey? I'd love to hear about your personal journey.
So my personal journey, luckily I've had 0 heart attacks, so that's good. But I do have 3 daughters, so probably one is on the way.
Oh, you're going to have
They are reaching dating age now, so something's going to happen. But no, I mean, I realized, part of that bell cracking was realizing how unhealthy my own lifestyle was, right? I mean, I was, in medical school, I remember I had a resident, he was a surgical resident, saying, we go by caveman rules on this rotation, which is eat when you're hungry, sleep when you're sleepy, and go to the bathroom when you have to, right? And so you're basically in this nonstop survival mode, right? And particularly, I think for me as an interventional cardiologist, everything that added onto my to-do list was like a life or death kind of thing, right? Someone's having chest pain, someone has this thing, someone ran out of this medicine and needs it, otherwise their stent is going to clot off. Somebody needs this procedure. Oh, my grandpa, just had a passing out spell. Can you get him in your already full clinic tomorrow? And it was just one of those classic situations of that like giving tree where you just kept giving. And then all of a sudden I had nothing to give anymore. And I kind of emotionally and physically kind of broke down. And then I realized, I call it kind of the caregiver sandwich, right? Is that like, if I, as a caregiver to my family, to my patients, to my parents, to everybody, if I fall apart, the whole house of cards falls apart, right? And I think that happened to me in my kind of early to mid 40s. And I think that's exactly the time where I see a lot of people, coming in with cardiac events, particularly men, because, they don't take care of themselves. Women, I think, are much better about maintenance care and kind of getting the annual screenings and annual exams. But, a lot of times I'd meet guys and I'd be like, oh, when was the last time you had, they would come in as a heart attack patient. I'd say, oh, what, who's your doctor? Oh, doc, I haven't been seen in the office since I needed a sports physical. I'm like in high school? Like, you're like 48 years old, dude. Like, that's like 30 years since you've seen a doctor. And that was probably a pediatrician. So, I realized that as kind of men of middle age, which I guess I am now, which is kind of, I don't like to say that out loud, but, we realize that we have to start taking care of ourselves. And even women, right? Like, all of us have to take care of ourselves because we are now in positions in our career, in our family, in our life where we've got so many people depending on us that we're like the glue that holds things together. And, imagine building a wall without mortar in between the bricks, like it will fall apart, right? It looks strong, but in fact, it's quite fragile. And kind of similarly, if you're not taking care of yourself, you may look strong on the outside, but internally you're quite fragile, right? So so for me, that involved exercising more. I was I always did a bit of exercise, and I used to do triathlons and all this stuff, but kind of focused exercise on what really matters. Like, yeah, you know what? I'm never going to be in a situation, even though I ran marathons, that I'm going to need to run 26 miles again. Like, that's just not what I want to do. But being strong, being flexible, right? Like working on VO2 max is a marker of longevity, right? And increasing my cardiorespiratory fitness. These are the things that matter. I don't need to have beach muscles anymore, right? Like, I'm old and married and shriveled up and nobody cares about me anymore. But, but what are the things that are going to keep me going? What are the things that are going to keep my mind going, right? What are the things that are going to keep my internal organs, like my kidneys functioning and my heart functioning and my lungs functioning and my liver doing well, right? Those are the sorts of things that I realized I can change through lifestyle, change through diet, without pills, without medications. And so those modifications were really eating better, making healthier choices, not living in caveman world, focusing on my sleep and learning how to sleep, right? Which is meaning like sleep hygiene and all that stuff. Breathing exercises have been really helpful for me in increasing my vagal tone, and really kind of focusing on that rest, repair, digest kind of mode of my body instead of the fight or flight mode. And I think the biggest mental shift for me was changing my expectations of myself, in the sense that, it wasn't that I had to get every to-do list item done every day, and that multitasking just kind of eats away at your soul, but just kind of picking the things that I needed to do, kind of learning to delegate the things that I could delegate, right? And then just being a little bit healthier about, if you don't get to this thing today, it's going to be okay, right? Like, you've addressed it, you've put it to somebody that if it needs to be escalated, they can escalate it for you. And that was a difficult shift, because I think a lot of us in the healthcare world, where we get here because we have OCD tendencies, right? And we have to, wash our hands 3 times and do everything ourselves. Otherwise it's not done right. But you just realize that, you've got support, you've got teams, and use them. So, that's what I focused on in my career, just in myself, in my personal journey to get better.
So if we could just sort of go into that moment where you now use the phrase, the bell cracked for you, and you started to question the adequacy of the education that you had gotten and started to look for more, look for other ways that you could treat people to make them understand themselves better. I mean, we talk about the fact that we have the most complicated system in the history of the universe and no instruction manual. And so we're trying to figure it out. We're all working together to try to figure it out. And the medical schools, certainly there's a tremendous amount of really important information that gets transferred into the brains of physicians during that process. But there's a few things that are missing. And RFK Jr., you mentioned nutrition being a big one. RFK Jr.'s just, laid down the law and said, listen, if you want to get federal funding for your medical schools, you have to teach nutrition, which I think is a wonderful thing. But there are also myths. As one, I'm trying to remember, I think it was UCLA said, a UCLA professor said, yeah, probably 50% of what's in our textbooks is wrong. So in your experiences, now that you've sort of cracked the facade and started to look behind the curtain and see that the Wizard of Oz is just some guy, what are some of the things that are the stories that are now being shown to be myths that are in
like
the field?
The myths I learned in med school? There's actually a book about, I think it's called The Myths I Learned in Medical School. And, I think it's great. I mean, part of it is, number one, I never feel bad for investing the time in medical education, because it made me who I am, right? And so I think for the physicians out there who are listening, that's kind of what got you here, right? And so you can never be upset. I think also part of it is you have to look at the goal of medical school, right? In terms of, they're teaching you to think a certain way, similar to like being an engineer, right? Like, it's not so much about the information that you learn, but rather the thinking process that's instilled in you, right? And so kind of similarly, yeah, it wasn't necessarily that the way I think of that is, and you go into medical school knowing this, right, is that I don't think that half of the information was wrong. I think that our understanding of the information has evolved on 50% of the information that we had back then, right? Because every discipline has things that we think made sense that don't, right? And so, when it comes to health, particularly because there's so much research going on, I think our knowledge and the science behind it kind of expands. I will say that there is a big concern about clinical trials and sometimes misinformation of data or misinterpretation of data. Or, people don't realize, you always need to figure out who's funding the trial, because that will oftentimes determine, how the trial was designed. And what most people who aren't clinical trialists don't understand about clinical trials is that you can design a trial not to fail, right? So when people kind of throw papers at me and they say, "Oh, you're an idiot. You don't know cardiology because look at this trial that I have. It shows the opposite of what you're saying." I'm like, well, who funded it, right? And so, you have to have kind of that meta awareness, I think, of that information. But, I think myths that I think, number one, again, I think a lot of it is, that diet and lifestyle do play a very important role, and we need to kind of make things shifted. I love that RFK is really, and Bonnie Hani, if you've heard of her, the food babe, like she's a crusader in this, kind of the work that they do to really allow us to see what's going on in our food and our diets and our lifestyle. And, they're starting with food dyes. And this is June of 2025 that we're recording. And there's just a thing about, I think Heinz Foods are going to take out artificial colors, which I think is a great move.
They're not taking them out. Just for the record, it's a bit of a PR move. What they said was that they promise not to launch any new products that have, and that they will remove any that aren't critical or somehow.
So it's impotent promises like that drive me crazy, right? Because, like we have all had, anybody who's in the healthcare field has had patients like gluten sensitivity in the US, and they go to Italy and eat all the pasta they want and they do okay, right? And that part of that is processing, but part of that is all the other additives and things like that. But, I do think that if nothing else, one of the myths is we have to have an awareness of what's coming in our bodies, right? And, there's just a trial that came over my desk about maternal exposure to PFAS and PFAS chemicals and the resulting risk of cardiovascular things like hypertension in their offspring, right? And so there's an uptick. So, not to put mom guilt out there, but mom or dad, use nonstick cookware, and all of a sudden their kids, particularly in the African-American population, are at an elevated risk of hypertension down the road, right? So, these things are scary. So making that part of the conversation, I think, is important. And that's not something that we get learned or get taught in med school. Then the other thing is, I don't want to say necessarily a myth, but something that we don't realize is how central metabolic health is to all disease processes, right? So cancers and brain, cognitive dysfunction and cardiovascular disease and GI diseases, right? Like
essential hypertension is an insulin problem.
All of these things, right? And so we don't really get an understanding of that. And I remember I was kind of like, I don't want to say the annoying, maybe call out to my podcast, The Curious Cardiologist. I was like the curious medical student, right? And I remember we had a lecture on diabetes, some world famous guy at our institution. And I said, so what causes diabetes? Well, it's a problem with the insulin receptor. No, but like, why? Like, why all of a sudden does the receptor decide not to work, right? And this was now like 25 years ago. And then, I just got one of those, answers that like he answered in a way that was like, shut up, kid. I don't want to listen to you anymore. But,
SOX 1 and SOX 3. And
part of it, we may not have had that, but I think also, in the medical school curriculum, we're just taught treatment with like some, whatever our primitive understanding is of problems, right? Like inflammatory bowel disease, for instance, we're taught, all right, Crohn's disease versus ulcerative colitis and transmural thickening and, all that stuff. But we're not like taught, why does that get set off, right? Why does that imbalance happen in the first place? And I think that's what we need to focus on, and that's what attracted me, again, like that hypertension lecture, is that finally we're kind of sorting out the root causes. Like I can count, 0 times did I hear the word glycocalyx, outside of the functional medicine world, right? And I think functional medicine, as a cardiologist, you can imagine I get a lot of hate on social media because people don't want to believe what I have to say, even though there's evidence for it. Again, it's that like living in that translation gap between bench science, basic science, and clinical world. But, there's people just don't want to believe some of these things. But, look at Lp(a). That was something that in the functional medicine world, we we're talking about 10 years ago. And now like everyone's like, oh, Lp(a) is one of the most important biomarkers. And if you're not checking it once in your lifetime, and in fact, I just watched a lecture, the National Lipid Association just released a guideline document on Lp(a). But if I had mentioned that to my partners when I was in practice like 7 years ago, I remember them saying, why you're wasting time, you're wasting money. Why are you checking this? Right. So, in a sense, I feel that our ability in the functional universe to kind of close that gap from bench to bedside, puts us at the vanguard of what's coming. And a lot of times because people are so used to clinical inertia and kind of, I don't want to say unwilling to change, but there's like almost like a built-in resistance to having to learn anything new.
There's a financial incentive. Think about the dietary cholesterol myth. The idea that dietary cholesterol has anything to do with your lipid levels. I mean, it does only from the standpoint, if you eat a lot of bacon, then you don't need to make as much cholesterol in your liver.
Right. And if, based on your absorption profiles and this, that, and the other, but it's just such a comforting narrative, right? For medical doctors to kind of have. I think of the Simpsons episode, right? Like when I was growing up, there were very few role models for me as an Indian boy on Simpsons or on television. We had Apu, right? The guy that owned the convenience store. And I'll never forget, he had this citizenship exam, right? He was going to be a US citizen and it was a big deal. And Homer was helping teach him how to be American. And it was just kind of funny stuff, like taking him bowling and drinking beers and stuff like that. But when he went for his final interview, the interviewer asked, all right, Apu, what caused the Civil War? Right. And like I saw this episode yesterday, he said, well, there were multiple causes of the Civil War. There's the industrial complex of the North and the agrarian republic in the South. And there was a tension between the economic forces, blah, blah. He was like launching this whole thing. And the reviewer said, just say slavery, right? Like, because that's the headline, right? And that's kind of similar to the conventional world, is that you just read the headlines without kind of underlying the below the scenes stuff. Like Lp(a), wasn't a headline 7 years ago, but if you read the article, you'd be like, oh, wow, this is a really cool emerging biomarker that I'm going to need. And so now that there are therapeutics, right? There's an antibody, there's like, I think 4 small interfering mRNA and different mechanisms to treat Lp(a). Well, now everybody believes it in the conventional world, even though we were talking about it so many years ago. So it's just an interesting mix in the conventional world. But yeah, I definitely think we need to up our game, right? And the problem is there's so much information, it's just overwhelming.
I'd love to dig into some of those biomarkers a little bit, coming from your cardiology, from a functional integrative cardiology perspective. Do you have like a top 5 or a top 3 biomarkers that you should be keeping track of and noticing for cardiovascular health specifically?
I think most of us think of lipid panel kind of when we look at that. But, I kind of, if you're just getting a conventional lipid panel, I think, the HDL to triglyceride ratio, or triglyceride to HDL ratio rather, becomes very important, because that's really tracking cardiometabolic disease, right? I think one of the things that we're not focusing enough on in cardiology, or at least we're starting to now, is the contribution of cardiometabolics to cardiovascular disease, right? So cardiovascular disease, I'm talking about the traditional things that I used to deal with: stenosis of the arteries, plaque formation, endothelial dysfunction, all of these things. But the cause of that is cardiometabolics, right? And I think we're just now learning this. And the scary thing is, there's a University of Utah study from, I think, about a year and a half ago that said 93% of Americans over the age of 18 are metabolically unhealthy, right? So there is a tidal wave of badness coming our way. And we really need to kind of focus on cardiometabolics and insulin and all that stuff. So oddly, I think that insulin is a marker, one of those biomarkers, fasting insulin levels, that we don't check because, for whatever reason, people don't think it. But I think it's a good marker, because normally you'll get a glycosylated hemoglobin A1C to check your average sugar over the last 90 days. But if it takes 3 times the amount of insulin to normalize your blood sugar, right? Let's say before that hemoglobin A1C could start, you're metabolically dysfunctional, right? Like that's like the red zone we need to get in before the fire kind of starts, right? Blow out the candle before the fire starts. That's the time. So I think that's an unused biomarker. Apolipoprotein B, ApoB, is a cell surface protein on atherogenic LDL particles. That is not part of the standard lipid profile that most people are getting. You can do all, like they call them advanced lipid panels. I just call them comprehensive, because I think that should really be the standard. But, so in the comprehensive lipid panel, you're getting an LDL particle number, which is different than the LDLP, which is different than LDLC, the concentration. But a cheap kind of proxy for that is apolipoprotein B, ApoB. And it costs like $10 or $15 to put on your blood work. So really, I think it's something that's important to check. Oxidized LDL particles, like damaged LDL particles, or something, I think, are another thing. Small dense LDL, again, that's part of a more comprehensive. Yeah, that's a more comprehensive lipid panel kind of thing. But I think small dense LDL is certainly something that you have to look at. And I have a personal beef with small dense LDL because it exists inside me in droves, and it hides in plain sight. You look at my conventional lipid profile, I'm on a statin drug, and my LDL number doesn't look that bad. But I have all of these small, dense LDLs that are the atherogenic bad players, that are, plugging up my arteries. So I kind of have to have my own lipid goals lower and optimize my cardiometabolics even more aggressively because of that. So those are some of the ones, outside of what you would normally get in a conventional lipid panel that I think are super important. I mean, but there's so many more. I do some work in an emerging biomarker called Clotho, and that is this really cool new upcoming biomarker of longevity. Clotho is a protein that is generally secreted in the kidney, in our brain, in our heart, in our muscle, and it's almost like an antidote to fibrosis signals like TGF beta. It's an antidote to proliferative signals that can cause cancer in the body. And I really think that is a really cool emerging biomarker that we can kind of explore for people to kind of get a sense of. It's almost like a state of the union check of how healthy you are. Clotho itself independently has been associated with longevity, meaning people with higher Clotho levels tend to live longer. There's association with brain health, with cardiovascular health, with GI health, with reducing cancer, all sorts of different things. And now, therapeutics for it. There's vitamins that you can take. I personally work with a company that has a bioelectric suit that you can wear that sends special electrical impulses through the body to increase your body's natural production of Clotho. So it's kind of, there's a lot of really cool things. But again, if you're waiting for the basic science to the bench side, that's going to take 15, 20 years. So being at the forefront, you really get to push this stuff out and make people better, faster. It's pretty cool.
I love this idea.
Yeah.
The bioelectric suit?
Yeah.
Yeah. So I think what's that?
What's it stimulating?
Yeah. So a lot of us, there's this whole new emerging field of bioelectric therapies. They call it electroceuticals. I don't like that term. It just sounds like you're just going to get shocked all the time. But low level electrical impulses that can have certain effects. And most people have probably heard of a TENS unit. And the idea behind a TENS unit is that you're low level stimulating the nerves to kind of decrease the signal to noise ratio. So you kind of blunt things, which is the same way that like Tiger Balm and Bengay and all that stuff kind of work, right? But here what we're doing with bioelectrics is with kind of these specific waveform patterns or patterns of the electrical activity, we can actually stimulate different things within the cell. So there is a group, there's at National Institute of Health, there's a whole conference on bioelectric therapies for cancer. So cancers will have a different bioelectric signature than normal tissue. So you can send these electrical signals through, not chemotherapy, not anything else, and kind of decrease tissue burden or tumor burden rather. And so similarly, what my colleague has discovered is that certain signals that are sent. So the suit looks like a little, like if you've ever seen like the suits that they wear in like Tour de France, the cycling kind of, so it's like spandex shorts and a kind of tight fitting top. And that's infused with these electrodes that plugs into a box. And that box will then send these electrical signals, these patented electrical signals that can increase proteins of longevity. And so we've got data on that. So it increases Clotho, sirtuins, which a lot of people have heard of, follistatin, a lot of these proteins. And so we've seen in human trials actually 30% increase in a lot of these proteins of longevity. So you can just, with that suit, it's called BodStim. You can just sit like at a Zoom, like I would wear it in Zoom meetings, I'd have it on and have a hoodie or something over, but it just looks like a black shirt. This is not the black shirt, but it just looks like a black shirt. And, you might feel a little tingle, but it's certainly not, you're not getting like zapped when you wear it, and it's kind of comfortable. It actually helps with muscle definition as well and weight loss. You're just kind of passively, you can watch TV while you've got the suit on for a half hour, and you're increasing these proteins associated with longevity. We've seen some so outside of just the lab work, we've seen some pretty amazing results, like people who have like shoulder issues or joint issues feel better immediately. The one that we weren't expecting was women with menstrual cramping. We have a version that's like a yoga pant for women. And I mean, I guess guys can wear it too, but yoga pants aren't a good look for all of us. JP, for you, it's probably a good look, but maybe not me so much. But a decrease in kind of these menstrual cramps from wearing the bioelectric suit. You don't have to be wearing the suit at the time of your cramping, but they told us, wow, like last time I had my period, it was intolerable. And this time I did the suit and I feel better. So I think we are learning a lot about the mechanisms of the bioelectric stimulation, but as well as Clotho as a potential agent to modulate this. But, it's really cool, interesting, and it's, I think that I just did a lecture on this at the IFM conference, a really cool emerging biomarker of longevity and health. Things that you can do. Exercise kind of increases Clotho as well. So we all know exercise is good for you, but why? right? Why is exercise good for you? Well, when you do cardiovascular exercise, you see a bump in Clotho. When you do strength training exercise, you get an initial dip and then a rise to 2 to 3x higher than your baseline level within 48 hours of heavy resistance training. So again, as we talked about kind of understanding the molecular mechanisms behind things, I think Clotho is a regulator of that.
So one of the things that I did sort of in preparation for this conversation, because I knew we were going to get to talk about Clotho, is to look to see whether or not or how the autonomic nervous system plays a role in the synthesis and release and production levels of Clotho in the body. And as I anticipated, but it was great to see that it has in fact been shown and is something that people are investigating, is that when you're in that chronically stressed state, that chronic sympathetic active state, Clotho production drops. And when you're in a parasympathetic recovery state, that state we tell people to get back into once an hour, once every 90 minutes, if you can, you see Clotho levels start to rise back up to where they should be. And I think it's all tied into, we've sort of hinted at it. There's the inflammation component. Atherosclerosis is an inflammatory process. The immune system's involved, but it's also triggered by the metabolic problems, the cardiometabolic issues, insulin receptor substrate being destroyed, insulin resistance, glucose intolerance, et cetera. And there's also this autonomic nervous system piece. When you're in that chronically sympathetically active state where you can't get back into that rest, digest, and restore mode, you end up with inflammation, insulin and metabolic dysregulation, and you see these cardiovascular issues crop up. And sure enough, you also age faster.
Well, yeah, I mean, I think of it like, I was mentioning how I did a marathon, but the story of the marathon, they won a battle of marathon and the guy ran 26 miles, told the king and died, right? So you can't be in this chronic go state, right? That's the thing, right? And production of Clotho drops, but I also think utilization of Clotho probably has to go up in a chronic inflammatory state. So as a result, the serum levels will drop as well because it's being used up. But yeah, to your point, I think in cardiology, we know the autonomic nervous system has some role, right? And we kind of, just like with, slavery, it was the cause of the Civil War, right? Kind of like that's the top line headline thing. But when you look at it as a mechanistic level, you talk about cortisol inflammatory responses and IL-6 and TNF gamma or TNF alpha or whatever, and interferon gamma, that's the one I was thinking of. And these levels in these chronic kind of sympathetic driven states, it definitely drives inflammation, right? And I always say atherosclerosis is misnamed. It's really atheroscleritis, right? Because it's an inflammatory condition and you cannot heal if you're running, right? Like what's the, if you tweak your knee running, what's the therapy? Well, rest and ice, right? Not running, not go harder, right? And I think in our modern lifestyle, we have this disparity
Goggins needs to learn that.
Goggins, I love that guy. Who's gonna hold the boat? But but seriously speaking, I can tell you, and I understand him. I've never met him before, but a great motivator. And he ran an ultramarathon with a broken fibula or whatever, and pushes through pain and facing your demons. I get it. There's a certain degree of that. But at the same time, the pain response exists for a reason, right? If you're, there's that classic joke, doc, it hurts when I press here, press here, press here. Well, stop using your finger to press, right? So, because that pain response kind of gives us feedback that don't do this, right? If it hurts to move, don't do that, right? But you will never get into a healing state in a sympathetically driven mode, right? And I think, Nawaz, you're the one that told me that, dropping bombs of wisdom
all the time. Yep.
To me, and that was just in passive conversation. He goes, you can't heal in a sympathetic state, but it makes so much sense, right? You can't heal a broken leg running on it. You have to rest. And kind of similarly with our bodies, what I was going to say is we don't really. We live in a state of death by 1,000 paper cuts, right? Because we are being pulled here and pulled there, and we had to put our phones on silent so we don't get bothered 1,000 times during this interview. And my kid wants breakfast, and I'm this, that, and the other, being pulled in so many directions that we have this very low level stress. Because it doesn't feel like, oh my God, there's a, my house is on fire kind of level of stress, right? But all these kind of paper cuts kind of have this summative added effect on our physiology, right? And that sets us in this chronic sympathetic driven mode. I mean, you look at, like, I run a wellness program, and part of what I do is give people a wearable so they can track heart rate variability. And it is like ugly. Like I'm like, are you compatible with life? Like, they'll have heart rate variability is like in the single digits I've seen. And I'm like, I didn't even know. And the first question I ask is, do you have a pacemaker? Because, when you have a pacemaker, there's an electrical timer. Being a cardiologist, so you can't really use HRV as a metric for people on certain medicines and pacemakers. And they're like, no. Like, I'm like, oh my God, how many hours are you sleeping? Oh, like I got like 4.5 hours last night, but I woke up a couple of times. I'm like, dude, like, before we've even talked about anything else, like, has anyone talked, like any physician talked to you about your sleep habits and recovery and kind of all of this stuff? And they're like, no. Like, why, is that important? Yeah. Like, I mean, it's crazy. And kind of on that subject of sleep, I tell people it's like that fish tank in Finding Nemo. When that filter goes off, the algae kind of grows, right? So similarly, that filter in your brain, the glymphatic system, kind of only functions or best functions at nighttime. So if you're not giving your body enough time to get rid of all those waste products and the metabolic things, they just kind of build up to where, yes, no surprise you can't remember where your keys are because your brain is inflamed, right? Like, dude, like it's
the thing it's trying to clear out is amyloid. And, amyloid protein aggregates ultimately and forms plaques. And that's what Alzheimer's is all about. So
yeah. Well, and getting back to Clotho, like one of the mechanistic things that Clotho does is it actually increases the turnover and the excretion of amyloid plaque in the brain, at least in mouse models. So we're doing some human stuff. But you're absolutely right. Like take the trash out. Like I remember one time I went to Athens and they had a garbage strike and there just mounds and mounds of garbage everywhere. The city reeked, and it wasn't like the beautiful Greek experience that I expected to have. The islands were awesome, by the way. If you get a chance, definitely go. But that's what's happening in our brains, right? Like, yeah, sleep is important, but oftentimes what's the first thing that gets eroded is sleep, right? Oh, I'm just going to watch one more episode of my TV show, or I'm just going to send out one more email and use my blue light emitting kind of thing to not only kind of delay my sleep, but also send to my brain signals that it's daytime, and so I don't need to sleep, and melatonin gets suppressed, and all the things that we know in this conventional or in the functional world.
Because in order to get that lymphatic system to flow properly, you need not to be in a stress state. That's why when you have stress that builds up in your life, you end up having a bad night's sleep. It's literally because norepinephrine is preventing the interstitial spaces to open up, and the glymphatic system, which is basically just pulling fluid out of the vasculature and flowing it through. It's like dialysis. It's like dialysis for your brain. You need to have acetylcholine released in order for that to function.
And for those who don't know, acetylcholine is the parasympathetically mediated and even sleep, by the way, you can have manifestations of stress. I mean, we're talking about my personal health. I didn't realize how stressed I was until I cracked a tooth because I was grinding my teeth so hard. I got fitted with a super sexy mouth guard at nighttime, and that was like, all right, I need to kind of focus on stress and exercise more and do my deep breathing and mindfulness and all that stuff, because, you think of sleep as a reprieve, but, it's a manifestation. And like when I cracked a tooth, I was like, okay, something needs to change, right? That is not bueno.
No doubt.
There's no bueno there.
Talking about sleep specifically, did you ever trade shifts with any of the other interventional cardiologists that were on call specifically when it was Spring Forward weekend? Did you ever work to avoid that weekend?
So I think the question behind that question might be that, there is an increase in heart attack during the daylight savings days, either the jump back or Spring Forward, because our autonomic cues and our circadian cues are out of alignment with one another, right? I mean, you talk about third shift workers, and like I had it's amazing that I even sleep because, my subspecialty was one where, someone had a heart attack at 2 a.m. You can't say I'm going to be there in a few hours. You like wake up and go, you get this autonomic surge. And oftentimes I actually have a COMT kind of SNP. So kind of my levels stay kind of elevated for a while. I'm not metabolizing out those catecholamines very easily. So I would be like jumpy. Like I remember I went to the gym at like 4 a.m. one time, and my, like one of my workout buddies happened to be there and goes, dude, you're here early. Like, did you wake up early? I go, no, I just been up all night and I needed to like burn off I call it burning off the crazy, right? So I did a workout just to burn off kind of all that excess kind of stuff I had. But yeah, I mean, autonomics, circadian dysregulation, all these things are huge. And the day-night cues, that we get need to be day-night cues, right? Like, I think that, that we don't appreciate kind of all of the things that we've created in life that disrupt us, like can lights, right? So getting LED can lights from the ceiling. I have my office here and I use a floor level lamp. It's actually a ring light that I dial in the warmth of the light differently as the day progresses, because like right now it's morning. So I've got the kind of the high Kelvin kind of warmth on, and then I'll turn it down at nighttime, and I turn down the brightness of the lamp as well to try to mimic as best I can kind of the outside light. But even something as the directionality and the wavelengths of light that are emanated screw up our sleep, right? And that screws up ultimately our autonomics, and knee bone connected to the thigh bone, kind of things fall apart a lot easier.
We saw each other in San Diego a few weeks ago, and I want to ask you, do you have any specific tools or tips that you utilize when you're traveling across time zones and you're kind of messing with your circadian rhythm as much as you do when you speak at conferences and whatnot?
Yeah, I think the first thing, when you collect gray hairs and wisdom, right? Like you can do a lot of things. So I've actually been a lot pickier about going to different time zones. Like particularly, I live in the West Coast, so East Coast conferences, unless there's a compelling reason for me to go, I just don't, because I know it's particularly stressful, right? I think that trying to realign with the local circadians, like getting up, seeing the sunrise, no contact, nothing that's going to filter the UV light, so like seeing the sunrise, sunset cues, I think become very important. I have dabbled a bit in melatonin, and I can't say that I've exactly hit the timing right, but using melatonin in a more kind of directed manner, I think is something that I've read about, and some of the pundits kind of talk about. So I've tried that, and then really just exercising to get tired, just being sleepy. But I just even at the conference that we saw each other at, it's an hour south of where I live, and I just have horrible sleep in hotels in general. So I think that's what I try. There's an interesting study though about, I don't know if that completely relates, about third shift workers, right? Because in the healthcare universe, people have to work night shift, and they looked at and it's well documented cardiovascular risk in third shift workers, and hypertension and metabolic dysregulation and all of that stuff. But this paper took an interesting take because they fed people or they forced people to eat during the normal times of day that work third shift. And so if you ate lunch at noon and dinner at 5 p.m. or whatever, but you still work third shift, you had a lower incidence of cardiovascular events. And so that meal timing is important. So I don't know what that means, but it's certainly interesting. So I don't know if there's a way to time your meals kind of more appropriately to shifting time zones.
I wonder whether or not by doing that, by forcing people to go through that entire third shift without eating, you're stripping out the junk food that they'll snack on when they're not hungry. And then the question is, are you because you're keeping them awake and they have a higher caloric burn as a result, are you effectively getting them into ketosis?
You're basically forcing them into intermittent fasting, right? It's like the best outcomes of intermittent fasting are the early morning fasting or eating windows, right? So eating from like 8 a.m. to noon does better than noon to 8 p.m., right? Or whatever it may be. Yeah, I didn't think about that. I think there's a lot of potential mechanisms there, but I think that the time shift is a vexing issue, right? And it's not just travelers, but like night workers, or even like ER people who work in the ER that'll kind of do swing shifts and all that stuff in the emergency department. It becomes a relevant issue. I mean, I remember I had an attending when I was in residency. When he would drive home after a night shift, he would wear a welder's helmet, right? Like, I mean, imagine a cop seeing that guy driving, like, what's Darth Vader doing driving next to me? This is in downtown Chicago. But, he was that concerned about his health. And now we've got the blue blocking glasses and all of these different things. But that was, again, 25 years ago. But, it's a real consideration, real concern that has real kind of cardiovascular effects, right? So yeah, great question.
You mentioned before we jumped in that you had a wonderful story or an interesting story about an autonomic, or the link of autonomics to a cardiovascular case. I'd love to hear that one.
Yeah, so this was at the VA hospital in Chicago, and that's where I did my internal medicine residency in Chicago. And I was a senior resident, and at this point, I'd been accepted into cardiology, and it was just like, and it was one of those rotations in the VA hospital that you love the people, but the systems kind of create a lot of kind of things for you. And so I remember, I was just kind of mentally done. I was already in my cardiology, mentally as I was not there. And it was like my second to last month of the rotation. And I was walking around and I heard this other team. It was a weird situation where there were two universities that shared the hospital. And so there's my hospital A and hospital B. So there's a group of hospital B. I was hospital A, and hospital B's residents were like freaking out about a patient in the room. So I was a senior resident. I just walked in and said, what's going on? And the patient was on a cardiac monitor, and they were in an arrhythmia called supraventricular tachycardia, SVT. And the interns were like all freaking out, as is appropriate, and calling in everybody. And they were going to, get ready to do a cardiac code and shock the guy and all that stuff. And I just kind of, without a word, walked in, looked at the guy. He was pretty stable, like his heart rate was definitely going fast, and he was kind of on the verge. Listened to his neck arteries, his carotid arteries, make sure that he didn't have any carotid disease, and just did a carotid sinus massage. He popped back into normal rhythm without saying a word. I just walked out. And these guys were like, who is this? That guy's Batman. Like, who is he? And I go, no, it's vagal tone. Like for stable SVT, that's something that you do. And, and I think in cardiology, we know the vagus nerve exists for things like that, right? But we don't appreciate the full role that the afferents and the efferents of vagal nerve kind of have, and stimulation effects and all that stuff. But it was like the first time where like looking back, number one, kind of a hilarious story to tell years later. But these people were kind of in the conventional world, and I was still a conventional doc, like afraid they're going to shock this guy. And the guys were like wide awake. And if you've ever had a defibrillation, even it's like getting punched in the chest by like Mike Tyson or Ivan Drago or whatever, right? From Rocky. It is not as comfortable thing. And just such a simple kind of carotid sinus massage, took him out of this arrhythmia, and he was okay. And so that's, the power of the vagus nerve. I'll never forget that, because everyone was freaking out, and I just, a simple maneuver did it, and, we used to talk about pressing on eyeballs and putting people in, their faces in cold water. I think there's a TikTok about calming down and putting your face in cold water. And I told my daughters, don't do that. Like, don't watch TikTok, but don't take medical information from TikTok. But, there's other things that can be done. But, the vagus nerve, I think in cardiovascular disease, they're so interrelated, right? And you talk about arrhythmia or hypertension or atherosclerosis or any of the heart failure, any of the big four in the cardiovascular realm, the vagus nerve plays an important role in each of those pathologies.
Heart rate variability itself is a function of the balance between the sympathetic tone and the parasympathetic tone. And that's happening on a beat by beat basis, that balance. And so to not understand the autonomic component of cardiovascular health, I just don't understand, because the same way medical schools don't teach about nutrition, they don't spend a lot of time talking about the autonomic nervous system. And the autonomic nervous system regulates 99.9% of what happens in our bodies. It's everything from literally gestational health all the way through old age. It's a controlling, some people call it the master control. And yet there's very little time and respect given to it.
I think it's a top line, kind of like a headline kind of thing, without really understanding kind of the consequences or the body of the text again, right? Because if you look at like heart failure therapies, for instance, right? Like, how do beta blockers work? Well, they modulate the effect on the beta receptor of adrenergic stimulation, right? So what are you doing? Well, you're giving them unopposed parasympathetic stimulation, less or more opposed, what am I trying to say? Modulated sympathetic expression to kind of hopefully kind of in a weird way increase parasympathetic tone. We talk about these advanced kind of technologies. There's a heart failure device that is a vagal nerve stimulator that you can implant around the carotids, and that, affects the pathways to the heart. And we see great outcomes in clinical trials for that device in heart failure. And that's implanted, but now you talk about transcutaneous, right? And it is something that needs to be studied a lot more. But my point is, we go through these great machinations, right, of implanting these crazy devices when you can do like carotid, transcutaneous carotid or auricular stimulation, and in smaller trials like see an improvement, right? There's this whole push toward renal nerve denervation for hypertension. Well, what are you doing? You're affecting the vagus nerve, right? And you're ablating a nerve that God put there for a reason. Like, yikes, let's all just take a breather here. You know what I mean? But, if you can put a device on outside externally and get that same carotid or a similar degree of carotid stimulation, or on the ear or wherever.
We've done that. That's
there's
super.
outcome trials for this, right? I mean, you guys, this is what you do, right? I mean, there's trials on this. It's just that, again, there's that gap between the science and the clinical world that we have to kind of somehow bridge and say, you know what? Yeah, maybe you don't need to implant a device, but do this for, 5 minutes a day or whatever amount of time. And I think, a lot of the confusion in the vagus nerve stimulation space is, laterality, right? Like, so like in the cardiac universe, we kind of say that right-sided vagal stimulation affects the sinus node and left-sided affects the AV node a little bit different. I don't know what that means. And honestly, you guys are much more in tune to that than I am. I haven't written a book on the vagus nerve, but dose, right? Frequency, all of these things that we think about with conventional pharmacologics, right? Like we need, I think, deeper study for that. But I think as cardiologists, we should also not deny the power of what we're doing and maybe not go like, guns blazing in and planting a device, a permanent device with the risk of infection and all that stuff when we can get a similar response through transcutaneous stimulation, right? I mean, it's really cool. And, and I talk about heart failure, but, atherosclerosis, right? Like sympathetic dominance leads to endothelial dysfunction, which I call it leaky vessel when you talk about atherosclerosis, right? Leaky vessel when you talk about vasovagal syncope, right? Or and POTS, like postural orthostatic tachycardia syndrome, right? Like there's vagal abnormalities there that are probably involved. And I'm not a POTS expert, but when we do tilt table testing, which is the test, you're looking for vagal nerve responses, right? Like that's something you're doing. Like hypertension, certainly. Like when you take deep breaths. I remember when I was a kid, I saw a news article or on TV news, ABC News or whatever, about looking at a fish tank for 10 minutes before you got your blood pressure checked, and it often brings it down. And my grandmother had hypertension. My parents were family practice. We took my grandma to my parents' office to check her blood pressure, and it was elevated. So my dad was like, all right, let's start you on this medicine. And that was when back in the good old days when he had samples of meds. And I said, Dad, just let's have her look at a fish tank. I just saw this thing on the news. I was like maybe 8 years old. I mean, I was like a fat little chubby Indian kid as opposed to a fat little chubby Indian adult. And like we checked, so my parents had a fish tank in their office, and those were like the closest I had to pets because parents didn't like pets in my household. And so I would take care of the fish. I'm like, Dad, just let's have her look at the fish, and her blood pressure dropped by 15 points. And my dad was like, how did he know this? I'm like, I saw it on the news. But when you talk about hypertension, vagal tone is huge. And oftentimes now when I get a consult for hypertension, the first thing I ask is not tell me about your family history or whatever. It's tell me about your life, right? What's going on? What kind of work do you do? What's your family life like? What is like, do you sleep? What are you eating? Kind of all of these things that can affect vagal tone. And a lot of times I think it's just those lifestyle interventions that you can take. I'm not saying that everybody's blood pressure comes down, but a lot of it comes down significantly.
I will tell you,
and
we conducted multiple studies in headache conditions, things like cluster headache and migraine. And what we did was we looked at, because we had baseline measurements and functional testing of blood pressure and HbA1cs. We had all of that information because you just get that at baseline and you do that at the various different time points. And what we found was that unlike medications, so I'm a normotensive person. That means I don't have hypertension. If I were to take medication designed to lower blood pressure, then I would have hypotension. It would give me lower blood pressure because it is doing it. It's sort of a dumb chemical.
Well, that's what it's designed to do, right? Block calcium channels, block the chemicals that lead to blood pressure.
Right. And so what we did was we looked and we said, okay, let's categorize the patients in the study with whether or not they met the criteria for being hypertensive versus normotensive. And then we looked 60 days later and we said, well, where's their blood pressure? And what we found was that the normotensives had no change in blood pressure. But the hypertensives dropped on average 14/9. Okay,
wow, which is huge for a blood pressure trial. But it completely makes sense, right? Because the normotensive individuals don't have the biochemical imbalances and the physiologic imbalances, right? The hypertensive people have the inflammation, have the elevated vagal tone. They're the ones that get the effect. And, get to your point, or what I was going to say too, is let's not discount the side effects of all of these medications, right? So if you can get away controlling or improving blood pressure without needing to put somebody on a biochemical poison, which is essentially what all medications are, and get them back into balance naturally, that's exactly what we should be doing, right? The body wants to be in balance. It's all this kind of Rube Goldberg Heisenberg machine crap that we put on that makes our lives complicated. But, like I think of, like, I'm a power lifter and I think of squatting, right? Like I have a coach that teaches me how to squat, and I have to go through I went through 2 weeks or 3 weeks of just sessions with a PVC pipe, super humbling, in the gym to learn where to put my hips and where to do that. But you see a kid, right, a baby that's just learning how to walk, and they squat with perfect form, right? It's all the things that we add on top that create these complexities that lead to these imbalances. But, in the hypertension world, yeah, if you're normal tensive, you're fortunate to not have to have all of these things that lead to these dysfunctions, that lead to the imbalances, that lead to these chemical responses by your cells of this fight or flight mode that puts it at biochemical warfare with your body, that lead to the inflammatory signals that lead to hypertension, right? I mean, that is the longest way of saying that. But that's the beauty, I think, of the functional medicine space and doing things like vagal nerve stimulation, is that probably those people, by the way, who are normotensive still got benefit, right, from the device, right? But one of the side effects they didn't have to deal with was hypotension, right? And that's exactly what we should be doing, is balancing the body naturally with things like vagal nerve stimulation, right? With deep breathing techniques. I mean, my blood pressure has dropped probably about 15 points on average just with breath work, consistent. The key is consistent. You can't just do it, for 4 hours on Saturday and live like a garbage, lifestyle the rest of the time, but consistent, unsexy breath work sessions for about 15, 20 minutes a day really pays those dividends in the long term, right? So yeah, I mean, I think that the external stimulation is a huge tool that cardiologists, probably number one, aren't really taught kind of how to respect the vagus nerve as much as they should. And then number two, we need to incorporate it, and the data is there, right? We've got data. I mean, I've seen the papers. It's pretty impressive. We just need to get that deployment, right?
And the results of that internal study that we did on our own data led board members and at the time the CEO of the company, both of whom, or those two individuals, were both on ARBs, ACE inhibitors, et cetera. They were taking medications to be normotensive, not getting there either. And then both of them went off their medications within 30 days of starting to use the device, just twice a day. And they were measuring their blood pressure. One was a physician measuring his blood pressure on 5 times a day. Didn't have another hypertensive episode in I don't think since, because
and that's the difference between treating and healing, right? With medications, you're treating a number, you're treating the blood pressure, but you're not healing the blood pressure, right? You're not taking care of the biochemical imbalances that are leading to that condition, right? And so what happens when you're just kind of treating the number is you get in this escalation warfare, because now, your body is secreting angiotensin 2 for a reason, right? Your body is secreting norepi and epi for a reason. So if you're blunting that response, blunting that effect, the body says, all right, there's a weird feedback here. So I need to give more of whatever that chemical is to combat this condition that I think is happening. And so, you're just in this, all right, well, we're going to bump up this medicine at your next visit. We're going to take this one up higher, and then we're going to have to add a third one in. And then, and you're never really dealing with the underlying issue.
It's just getting worse.
And as we were talking about kind of at the top of our segment of, why did I get into this? It was exactly that, is let's heal people instead of treating people, right? And we are excessively awesome kind of at treating people. We're horribly bad at healing people, right? And that's what root cause medicine, kind of dealing with these things at a very kind of biochemical, molecular biology level. You're fixing cells, right? You're fixing the imbalances that lead to these dis-eases, right? You're putting the body back in ease mode, which is parasympathetic mode, right? Rest, repair, digest, chill, right?
Mostly.
It's
when you're capable of having that resilience to shift between the two states.
Well, the world's going to push you out of homeostasis. The world is stressful. You got to live with that. But
it's the capability of coming back to parasympathetic.
Well, I tell people all the time, I can never take away stress, right? That's adulting 101. You're going to have stress, right? But it's how you manage that stress, how you digest it, right? And then ultimately, kind of to your point, Noaz, is getting back, from that sympathetic to that parasympathetic state, right? And like not letting that guy who cut you off in traffic ruin the rest of your day. But I kind of, my girls just learned how to drive. So I taught them and I said, okay, whenever you get cut off or someone's mad at you, just imagine they have really bad diarrhea and they have to get home to, right? And then you're like, oh God, that's kind of funny. Like that poor guy needs to get to the bath. Like you change that framework in your mind, right? So yeah, I agree. Maybe I said it kind of incorrectly, but having that grit, that resilience to go from that sympathetic state to a parasympathetic state a little bit more easily, right? Building that bridge, putting another few lanes on that highway so that the traffic flows easier, right? Like that is kind of what the goal is. And yeah, you can't take away adulting. You can't take away stress. If you ever watch that show Yellowstone, like their ranch is always being like attacked by somebody. Like that's kind of being an adult. I think that's why people relate to that show so well. And it's like, obviously you can't take people to the train station all the time, but like getting back in mode, mindset, right? I think like is something that we talk about, or I talk a lot about in my program is, just change your mindset. Yeah, that poor guy has to get to the bathroom, so that's why he cut me off. Or, what, that person is really having a bad day. You don't know, and we all know this, you don't know the stories of everybody that you interact with on a daily basis. So give people grace and kind of have that gratitude, abundance mindset, right? To say, oh, hey, that person is in a hurry today. I'm not. I'm lucky to not have to be in a hurry. So let them go by, right? Let them go in front of me. They've got 16 items in the 15 item or less lane in the grocery store. Well, they, maybe they need to get back or something. And it's those little mindset shifts on a daily basis. It's the unsexy things, right? That kind of really extend your life, so it's not jumping in a cold bath, although that may have some benefit. But, I think for me, it's the mindset of, all right, let the people, I don't know what's going on with them, or they're under stress or something I don't understand. Somebody, we only get to control our reaction, right? Not the action, like kind of a really bad paraphrase of Viktor Frankl. But those are the things that can keep you in kind of that more parasympathetic mode and then not engage that, fire mad, as my kids call it, like level that dads can get sometimes, and just, try to chill out.
I love this. I really think one of these big takeaways from today's episode is this difference between treating and healing. I think that's such a powerful, simple, but powerful thing that people should take home and understand. And from my perspective, the difference between treating and healing is awareness and mindset, right? Internal awareness. What's really happening inside? Why do I feel the way that I do? Understanding that there is a cellular mechanism that your body is trying to react to, and the medication is simply blunting that response, versus the healing process is trying to eliminate the root cause in the first place and allow the body to do the job that it needs to do to heal, to get back to optimal state of function. I think that's so huge, so powerful, and such a huge takeaway for anybody who's gotten to this point in the episode. I want to kind of work to wrap this up. JP, go for it.
Yeah, I was just going to riff off what you just said, which is, we've talked in the past about mental health drugs, antidepressants. They're a class of drugs where inevitably people have to escalate their doses or move to different medications. The same is true of medications for headache. Many times people find that while headache medications may help them briefly get out of having a migraine, the more you use them, the more frequently those headaches occur. The same thing happens in asthma. The more you use the bronchodilator, the more unstable you become, the more sensitive your airways and reactive your airways become. Same thing is true, we just talked about in hypertension, and the fact that you start on an ACE inhibitor, and before you know it, you're taking an ACE inhibitor and an ARB, and then you're talking about biologics that might come down the line. What we need are medications that don't put a Band-Aid on it, but in the process lead you to have that limb cut off. And that really is where I think the autonomic nervous system and how you can regulate your lifestyle, diet, sleep, stress management, and insert this autonomic nervous system regulation really helps you treat the acute problem that you're having, but in a way that actually teaches your body how to manage its situation better. It gets you back into homeostasis. Most of these things knock you out of homeostasis, even worse.
Yeah, no, completely agree. Yeah, I mean, I think it's like you said, it's such a simple but powerful statement. I'm sure I didn't come up with it. I must have read it somewhere. But we need to change our mindset, right, about disease, and particularly chronic disease. Look, if you have a heart attack or a stroke, I'm not saying you can do vagus nerve stimulation and get the clot deliced, right? No, go get the clot taken out of your brain. I think we do very well in the acute care setting, but the chronic disease management, right? I think that's where conditions fail. You mentioned, JP, meds for depression. I mean, there's clinical trials that show that these depression meds don't work, right? Like really, right? I can't remember the name of the trial right now because it's not a cardiology. I have all the cardiology trials in my brain, but I remember someone was talking about TMS, transcranial magnetic therapy, and or stimulation, and looking at this depression trial, and it escalates. But even there, nutritional support, magnesium, zinc, right? All these things can play a huge role in reawakening our synthesis of the neurotransmitters. And now, serotonin, so many of these depression medications work on serotonin, but if you give your body the milieu to create it, or if you do like genomic testing and you've got SNPs and you kind of work on kind of dietary control or targeted supplementation or exercise or whatever it may be, you can overcome some of these genetic SNPs that can predispose you to lower levels of serotonin, right? And again, that's not an easy path as a physician because it's so much easier for me to say, here's your sertraline or here's your, whatever, insert depression medicine here. And, it may work, but, I think the thing about the psych medications is it's like once you're on it, it's a life sentence, right? And it doesn't need to be. Like, I can count as many times as I had nutrition lectures in med school, I think, is how many times I've seen someone be taken off of a psychiatric medication, right? Which is a big donut, zero. But, nutritional support, all these things you can see, like even, I've seen through my program, like people that, like young people that have depression, do the program, we're healing their gut, we're getting their microbiome, we're getting their micronutrients in, and all of a sudden that depression lifts, the anxiety lifts, and they can function again. And it's just, it's a testament to the power of this approach of medicine and why, I believe in it so kind of in my bones deeply that I left a conventional practice to pursue this, because I think this is really what medicine is, right? One of my other taglines I say is the future of medicine is not medicines, right? It cannot be, right? It needs to be diet. It needs to be lifestyle. It needs to be making humans whole again through putting humans through what our bodies were designed for, right? You put diesel fuel in a gas engine, it falls apart, right? It just doesn't work because that's not the fuel it was designed to work on. So similarly, our bodies were designed to be, not work on ultra processed foods and high fructose and kind of, red dye number 6 or, enter bad chemical, PFAS, BPA, whatever here. It wasn't designed for that. So if we can return to kind of what our bodies were truly designed to be fueled on, health is almost a side effect of balance, right? Weight loss is a side effect of balance. You mentioned headache. I had a woman that did my program, migraine headaches for years. Within the first 2 weeks, her migraines disappeared. She didn't realize that the foods that she was eating had such a significant effect. Her husband was also like, yeah, have you seen this before? And go, yeah, it makes sense. There's probably a dietary trigger for her migraines. Who knows what it might be. My mom suffered from migraines. So for her, we knew almonds were a trigger. But he had told me, yeah, no doctor has ever talked to us about this before. They just wanted to escalate on this medication and this triptan and that drug and whatever. But it was something as simple as eating the right foods, put her back in health. And I said, yeah, because the body seeks balance, right? It's all these things that we do that put it out of balance that lead to these conditions, right? So I think you're exactly correct, JP, and you too, Nawaz, when we talk about this.
Just to tie a little bow on this, you mentioned it. Health, the word health actually comes from the root word heal, and the root word of that comes from the root word of whole. Health is wholeness. It's fullness. It's becoming whole again. And I love that you kind of brought that idea up. So I just want to bring that linguistic piece in just to tie a bow on this. Where can people learn more about your program, the work that you're doing, and the Curious Cardiologist podcast?
Yeah, so you can follow me on Instagram or any of the socials at Dr. Sanjay MD, so DOT CORSANJAY MD. My program is called Well 12. So it focuses on really kind of, like you talked about, making people whole again, the 12 dimensions of wellness. It's not just about your blood sugar number and your cholesterol number, but spiritual connection and community and breathing and all of these things. So we really kind of teach people through the 12-week program how to put that together. So it's called Well 12. You can look for my website, lagunalongevity.com. And if you're in California, I do have a small telehealth practice. So if there's something I can do to help you out there, you can find me through Laguna Longevity, and we can go from there. And I am launching my podcast. It's called The Curious Cardiologist. I hope that you guys will hop on my podcast as well. But really with that, the idea is to dive into whatever it takes to make people feel better, right? So it's not just functional approaches, but we're going to be talking about like red light and diet and even, conventional medical therapies that may be of benefit. But with this lens, rather than of focusing on you're right and I'm wrong, or I'm right and you're wrong, is really, let's put the patients first. Let's put Humpty Dumpty back together in a sense, whatever it takes to get people back together so we can focus on getting people back to life and enjoying their, the whole point of living is to live, right? And so getting people back to vitality and health and longevity and all of those things. So find me on any of those channels and I'll be happy to hear what you have to say.
We're going to put all of those links in the show notes for anybody who would love to connect with you. Sanjay, this was wonderful. What a great conversation. Phenomenal to have you here. JP, any final words?
Yeah, it was great meeting you. I look forward to continuing the dialogue. There's so much more I want to talk about supraventricular tachycardia. I want to talk about Alexander Fleming and the fact that I have a great picture. I'm going to say this right now. We talked about Alexander Fleming. He's the guy who didn't clean his dishes, went away on a sabbatical, came back and saw the mold and the bacteria fighting each other and figured out, hey, maybe we can use this to treat bacterial infections and made penicillin. But I have this great, it's a picture of Alexander Fleming. He won the Nobel Prize. And then there's a letter that he sent in response to a communication he got from a woman from New York, in which she had suggested the idea of putting antibiotics into soap. And his response was, I don't think it would be very effective. I think it's not going to work. But there's some entrepreneurial people in the United States who might be interested in this. So the guy who got the Nobel Prize for winning couldn't figure out that maybe antibacterial soap would be valuable.
Well, I mean, we can even talk about the skin microbiome and why I think antimicrobials are like the soaps are like the worst thing to happen to our skin microbiome. And I mean, so many conversations. So yeah, I will, if you guys have me, I'll be happy to come back and chat about that anytime.
We will absolutely have you back. This was a great episode, great conversation. Thank you so much for joining us. And if you got to this point in the podcast, please share this episode with 1, 2, or 3 people who you think could really benefit from hearing this information to optimize and get their health upgraded. We'll see you all on the next one.